Good evening, everybody. This is Dr. Bruno Azevedo. Tonight I'm actually talking to you from Chicago, Illinois. I'm an endodontist and I'm a radiologist based in Austin, Texas. And it's a pleasure to talk to you guys tonight about laser activated irrigation, or LAI. This is a very hot topic in endodontics. I'm quite sure I have colleagues from all over the US here with us tonight. And it truly is a pleasure to talk a little bit about my experience using lasers in endodontics, particularly from the company J. Morita. Full disclosure, I am a paid speaker for J. Morita as a consultant, being a Morita user from their laser now for about a year. And I'm also being their national consultant for imaging. But it's very straightforward to say that today, it's probably the best time to be an endodontist. There's never been a better time in human history to treat patients. I think that every one of us that goes to practice right now are having the time of our lives with all the technology that we have available to us, whether that be, rotary files, advanced irrigation, cone beam CT imaging. It's been an amazing sort of a journey for the last few years with the amount of technology that we have available to us. And this amount of technology and this amount of excellences that we have in care made a guy like me that was a radiologist for 24 years want to go back to school and become an endodontist. I really wanted to touch and go back to clinical dentistry after over 20 years, just because of all the technology, all the really cool things that can be done today. And I was very fortunate to go to what I like to call the heavens of endodontics. I was trained at Einstein Medical Center in Philadelphia, and there I call it Einstein Endo Laser Heaven. And and the reason for that is because of those two gentlemen here. I was trained by Dr. Fred Barnett and also by Dr. Steve Nimzik, which from very early on my academic career were very big supporters of using lasers and literally showed me the way on how to use lasers clinically. And I would encourage anybody that has questions about lasers to literally go to Laser Heaven, which is Einstein. If you don't believe me, we actually had here a photo of a couple colleagues that came all the way from Australia. This is Dr. Alex Lee and Marcus Young. And they were just mesmerized by the amount of technology that came out of this tiny little clinic in Philadelphia. So this was our routine. We had a chance to experiment with all kinds of lasers that you guys can imagine. So I do have clinical experience with, many cases over, using each one of those lasers. And I come tonight with you guys to talk about the fact that those lasers are awesome in dentistry. You cannot go wrong with a laser. So just to give an example, this was my first laser case ever. And I was working on those, on the central incisor. And the idea here is, this lateral incisor. And the idea here was that I was able to do and perform this root canal without any rotaries. So basically, my axis was done with the laser. So here's the tooth. The axis was done with the laser. Instrumentation was done from a MIE perspective. All my irrigation was run through that little pinhole. And here's my final obturation. This case has healed beautifully, and I'm super happy with this result. Again, this was literally my first case using a laser, and this is coming from somebody that spent 22 years without doing root canal. So I was very happy with this and became a believer right away on all the applications and the technology that we can use for cone beam CT imaging. For lasers. So here's the final result. So moving forward there at Einstein, right? And this was an amazing journey. We also had a lot of speakers that came to our program, including Dr. Carlos Esterla, that was, very adamant on the fact that, and I'm just going to video clip. I'm going to share those controls here just a second, see if we can hide them. There you go. So now we can actually see. So Dr. Carlos Estrella came into our program, and on one of the lectures, this slide spoke very intensely to me, which was that right now we have to understand, train, and integrate technologies that can really enhance endodontics, particularly now that we are living in this 3D endodontic phase. And when I say 3D endodontic phase, I mean by the fact that we are now doing our diagnosis in 3D. We are now shaping the tooth in 3D. We are irrigating the tooth in 3D, and we're filling the tooth in 3D. So I'm a strong believer that in 2024, we can truly call ourselves a 3D specialty because, again, diagnosis in 3D, irrigation in 3D, obturation in 3D, in 3D. And this is coming from our imaging technologies, our irrigation technologies, and of course, our obturation technologies, whether that be with sealers or oddity. Now, when we go back to the endo side of worlds and going back to the interesting beginning on where we're dealing with, it's very safe to say that when we look at those two cases, we know the basic differences between them. One is a vital case, the other one is a necrotic case. Every time that we have a vital case, we know that we have better results than a case that has AP. We absolutely know this as endodontists. And that makes you think, right? Why are we not getting the same success rate from a vital case to a case with the EP? Why are they different? Why is it that every time that I have a case like this with a large apical periodontitis, I don't have the same prognosis, the same outcomes as a tooth that was just vital with maybe some irreversible pulpitis? And we know the answer to that. The answer to that is because this type of disease is a biofilm disease. It's microbes. So everybody out there doing root canals, we have one enemy in common. That enemy are microbes. And when we look at outcome studies, right? I stole this slide from my mentor, Dr. Barnett, but I love it, which is the fact that when we go historically speaking and we look at all the studies that were done and we compare the results between the outcomes between teeth with lesions and teeth with nose lesions, it's clear as day that teeth without AP have a better outcome. So when you take that into consideration and you also look at the fact that we are now looking at prevalence of AP on a population that's older, which means that this particular population will have a weaker immune system. And if you think that the success of endo, it's 90%, and we think that there are 400 million root canals filled in the United States, even though we might be at 90% success rate right now, there are approximately 42 million root canals failing in the United States. Even if our root canal it has a success rate of 95%, that would be over 20 million root canals being failing right now in the U.S. This is a really large number when we think at a population, which tells us that we do have a problem in endodontics, which is we need to bump our success rate because it's not 100%. And in that perspective, I know nothing gets to 100%, but we need to get as close as possible to that. And I am a strong believer, understanding now the osteoimmunology that I do, with the imaging that I do, and also what we can do with advanced irrigation, that there is more in endodontics that we can improve. And I'm a strong believer that lasers can be a strong ally towards that goal of improving endodontics, a little bit of a time. So when we look at endo in general, right, mechanical endodontics, we know through the countless studies that have been published in our literature by Owen Peters, by Ricucci, that when we are looking at what it's obturated, we are not really touching all the walls of the root canal system, which means that we are definitely leaving behind some tissue and, of course, microbes. And when we look at those cases, now this is like beautiful histology from Ricucci, it's very clear that you see here the bacteria, not only around the walls, but particularly when we look very closely here, we do see bacteria inside those dentinal tubules. And it's important to stress that right now, we don't have a lot of penetration of irrigants inside those dentinal tubules with conventional endodontics. So whenever we're dealing with teeth with AP, we are dealing with this nasty, nasty little bugs here, biofilm. So we know that we have intraradicular biofilm, and of course we also have extraradicular biofilm. And there are times that during the root canal procedure, we're going to be pushing that particular biofilm and maybe create a problem. So biofilm being the enemy, we have to now evaluate and see where do we find those biofilms around the tooth. So this is a micro CT of a tooth that was extracted, and what we can clearly see here are those high density areas right at the surface of the tooth. So on the cervical area, you can see the little higher density part right here. This is definitely biofilm, but when we start looking inside the tooth, and the anatomy inside the tooth, every time that you see this high density findings here, they are actually showing us the presence of biofilm inside the tooth. This is at a furcation level, and you can see here, you can appreciate the high density findings. But when we start looking at the root canal system, even on lateral canals, you can clearly see that there is a higher density in this part. And that higher density, those are our enemies. That is a colony of biofilm. So that intricacies here, that imaging is now revealed, and histology is also revealed to us, is that there is this presence of biofilm, and we need to disrupt this with everything we can. There are situations that we can disrupt this with files and, create pathways to get irrigants here. Some other times it's virtually impossible. And the reason for that is we are dealing with three-dimensional objects. We are dealing with structures that are complicated anatomy. They curve. I don't need to go too crazy here on the importance of microanatomy, but the teeth that we're dealing with, they are not just truly one single canal. They are a system. They are very complex, and each one of those tiny little minutiae can hide a lot of microbes that are one of the reasons why we have a success rate differently from teeth that have AP versus teeth that are vial. So when we understand this particular concept, and we know that our biggest enemy are microbes, and those microbes are going to hide inside this anatomy, we're going to try to elevate the level of endodontics that we're doing to try to combat those microbes. And the only way that we can actually kill and disrupt biofilm and microbes is, in a matter of fact, a chemical warfare. Now, whether you're using sodium hypochlorite, EDTA, Triton, in the end of the day, we are all ranging chemical warfare at the apex of the tooth in order to kill as much microbes as possible. The challenge that we have, it's what you see on this particular slides, and those are bubbles. Bubbles, if you're using traditional irrigation, are going to be your enemy, in the sense that those bubbles are going to create what's called a vapor lock, and is going to prevent that chemical warfare to be raged at the apex of this tooth, because irrigants are not going to be able to reach the apical part of the tooth. But as we'll see here in a little bit, with the lasers, the bubbles are actually our best friends, because they're going to move in extremely high velocity. They're going to explode around the dentinal tubes, and they're going to disrupt that biofilm, enhancing the irrigation that the vapor lock itself prevents us from doing. So it's actually very interesting when we think about the differences between those two characteristics of the bubbles here in irrigation. So Now that we know that we have the presence of microbes, we look at micro CT. We know that this anatomy is there. We have tons of cases on social media showing us, how much crazy anatomy is out there, particularly with sealers. We have to absolutely try to make this as clean as possible. So one thing that I tell everybody is that there are no really truly easy root canals. There's no such a thing in my mind as a straightforward root canal. Same goes with imaging. Every time that we take a cone beam, there's always something there that tells us that something is different and unique about that patient, about the anatomy that we're dealing with. So it's really important that we respect the root canal system and never, ever, ever consider something simple. Even though it may seem simple, it's never simple. And with this in mind, and trying to get to those nuances, how are we going to achieve that? How is it lasers going to help us get there? We spent 100 years trying to figure this out, and we are getting very, very close in 2024 with the level of technology that we have available to us. And it starts here with the experience that we have with the Merida laser, right? It's been quite a journey to use the laser. This is something that is really cool when you're doing the root canal system. Canal is very satisfying. That's the middle a lot of structure that was so much was left behind, which is not good. And the laser in endodontics can be used in this scenario, not only for irrigation cycles, but also for surgeries and all these things. So what is laser? So laser stands for light amplification stimulated emission or radiation. And again, one more time here, let me hide this. So light amplification by stimulated emission or radiation, that's lasers, right? Interesting enough, it was discovered by Einstein. Yeah, one more shout out to the Einstein folks in Philadelphia. And right away, the moment that I start using this technology, I became addicted to it. Dr. Barnett likes to tell this story about one of my first cases using a laser where I found myself blocked from debris. And I was like, Dr. Barnett, I'm blocked. What should I do here? He goes, you know what to do. It's right next to you. Just use the laser. And sure enough, it's one of those things that it's really hard to explain what you expect until you actually touch it. And you see how laser energy can truly help you do better endo, better, faster, meaner in many ways. And what is interesting about the lasers, and this is something that I want to also talk to you, it's about my journey and understanding what is it to be expected the moment that you start using lasers. So the first thing you will know is that if you ever decided to invest into a laser system, is that a couple of things will change towards your workflow. And one of the things that you will change is that from that point on, your patients and your staff are going to have to wear safety goggles, okay? Those particular safety goggles here are not your average safety goggles that you use for your, like sunglasses that you use at the beach. They are actually very expensive. They cost anywhere between $300 to $500. They typically, when you purchase the laser, they will come with those goggles. But it's important because what they are doing is they're protecting your patient's eyes from potential radiation coming from the laser. Can you blind somebody with the laser? No. Doing a root canal with the laser, are you putting your staff or yourself or your patient in danger? Absolutely not. But it's a requirement, and it's something that you should expect to have available to you when you decide to use lasers. Interesting enough, if you are like my colleague John here, who is using the microscope, you will see that he is not wearing goggles. And typically, if you are using a microscope with the lasers, you're not going to require to wear the safety goggles. However, Later on, if you're using diode lasers and you are using loops, it would be required for you to have some sort of eye protection, okay? But through a microscope, you'll be fine. So it's going to be important that you have this around. Patient and staff will have to wear laser safety goggles. The other thing too that I can't stress enough is that in endodontics today, we will need 3D imaging. And the idea here is you will find yourself blocked. You will find yourself with crazy anatomy, but with minimum instrumentation and lots of irrigation, you will be able to achieve results similar to this that I got on this case, where you can get to what's called laser patency. So the use of lasers during the instrumentation part, particularly during the irrigation part, will allow you to maximize the amount of time that you want to achieve the results that you want to achieve on your cases. So you're not limited to 2 minutes, 3 minutes, or 8 minutes, or 10 minutes. It's as much as the case needs, and this is something that it's awesome when it comes to lasers, in the sense that you're not bound to a specific time. You can take your time on cases that are really hard, and if you need to do 15 minutes of irrigation, you will, right? So I love the fact that the laser allows you to extend irrigation times, particularly when you have hard cases like this. And due to the amount of time that we have today, I wasn't going to spend a lot of time, on the physics of the lasers, but there are some terminology that I think it's important that you should know. So one, it's energy, right? So energy, it's the ability to do work. We measure that energy in joules, or in this case, in lasers, a lot of millijoules. So we're going to be using this terminology a little bit when we talk about settings. So just remember that energy, or millijoules, it's the ability to do work. The other thing that we also use, we talk a lot about in lasers, are power, which is work performance over time. We typically are going to measure this in watt. And we also need to talk about power density, which is the power per area, or watts divided by centimeters squares. I know this is, kind of a boring from a dental perspective, but when you start using with lasers, you do have to go back to your physics a little bit and better understand settings, and better understand what does it mean to change your settings, because you will be changing this particular millijoules and watts and hertz as you go along, so the laser can do what you want the laser to do for you. Now, when we talk about lasers in dentistry, there are different types of lasers, of course, out there. You're going to have your diode lasers. They're going to be, in the neighborhood of 750 to 980 nanometers. But the two major ones that we talk about, particularly in endodontics, are going to be the YSGG laser, which is about 2780 nanometers, and the Urban YAG, which is 2940 nanometers. As you can see here, they are very, very close to, in the electromagnetic spectrum. They're right next to each other, but at the same time, they're fundamentally different. The analogy that I like to give here, it's imagining like San Diego and Tijuana. Not the one is better than the other, but you have San Diego, which is a few miles away from Tijuana, and you cannot have two different worlds, right? It's the same thing here with the YSGG and the Urban YAG. So when you compare both lasers, they're both great in endodontics. I had the pleasure and the privilege to work with units that have both wavelengths, and they are both fantastic. One of the things, full disclosure, I don't think that you can actually tell the difference between the irrigations clinically wise or outcome wise between irrigation between those two. I don't think you would ever be able to tell the difference. They both work great. But the YSGG will emit, like I was saying, the 2.78 microns, which is better absorbed by hydroxyapatite. So this particular laser will have the absorption of energy tailored towards the mineral component of the tooth. it's amazing for caries removal, surface modifications, hard tissue in general. But when you compare the Urban YAG, which emits the 2.94 micrometers, the wavelet here will have a higher absorption in water than the YSTG. So this will lead to more efficient ablator on water-rich tissues like dentin and enamel. So they are very close, but at the same time different. One will act a little bit faster on those mineral components, where the other one is going to work a little bit faster on water-rich tissues. And when we talk about the ablation and thermal effects, the deeper the penetration into hard tissues, you can lead to more ablation, potentially larger zones of thermal necrosis or heat damage. I'm not saying here that those guys will cause damage inside the tooth. One of the things that I want to be very clear here is that my time at Einstein, I have never, and this is, with hundreds and hundreds and hundreds of root canals, if not thousands between all the residents, we have never observed thermal damage to dentin using lasers, okay? Now, the Urban YAG will have a shallow penetration, is going to be less efficient from an ablation perspective, particularly when it talks about bleeding, but it causes minimal thermal damage. So one major difference between the two systems is that when you're dealing with a bleeder or you're dealing with gums that are bleeding, yes, the YSTG, it's a little bit better than Urban YAG because the Urban YAG will have a shallow penetration. All that means is that you're going to have to spend a little bit more time using the laser over that area to achieve the same results. But ultimately, I'm a believer that you can get pretty much the same results using both lasers. So when we talk about this penetration, right, what the Urban YAG is doing and what the YSTG is doing, just from a visualization component, I would like to show you this particular slide. This slide talks about the fact that this was, you can see here diode laser, an ND YAG laser, a CO2 laser, and a Urban YAG laser. When you compare those guys, you can see that the one that had the least amount of damage, or at least thermal damage to this particular liver, was the Urban YAG. So you're not going to have too much depth in penetration and also not too much ablation to it because this laser likes water. So you will seek that and not have any issues related to this. So going back here, look, the Urban YAG will have very little penetration. That's why it allows you to have a lot of control, particularly when you're doing perio and you're going around the tooth, for deep margin elevations and things of that perspective. So one of the things that the Urban YAG laser will allow you to use, it's going to be the fact that you're not only using this for endo, you can use this for for different types of soft tissue issues like this one. You're just removing this little mucus cyst from the lips, and the healing that you get from the laser is just amazing. I've had a chance to work with lasers for frenectomies, and kids, they withstand the laser really, really well, even with just topical anesthetic. So it is a good thing for you to have in your practice because it opens up a gamma of opportunities that goes beyond just irrigation. You have the irrigation part, which is important, but it's also important to stress that if you want to invest in a laser, would be my advice to invest on something that allows you to do more than irrigation, because lasers are so amazing when it comes to, surgery, little biopsies like this, and management of soft tissue. Now, I got this slide from Dr. Fernando Meza, who is a dear friend, and he talks about the laser-assisted endodontics in 3 phases. Debridement, which is when you're going to start removing the organic, inorganic, stuff from inside the tooth. You're going to have the bulk disinfection, and this is when you're going to be using your laser for irrigation, and particularly is going to be the main canals and the apex. And then you're going to have what's called the deep disinfection. And this is where I think the laser shines, particularly when it comes to comparison among lasers and traditional methods of irrigation. So what does that mean? That means that when you start using your laser, you're going to particularly for those who have never done this before, the laser is a little bit different than what we are used to in dentistry because you really don't have tactile sensation. Everything that you do with a laser, it's an understanding of where is that laser tip and the distance to the surface that you're working on. Okay, so one of the things that you will not do with the laser, it's actually have that tactile sensation. Another thing that's also interesting is a lot of times when you're inside the root canal, you activate your laser on the way out, not on your way in. And this is, for those who have never used a laser, this is an interesting thing because when you are trained as an endodontist, everything that you do, you're activating on your way down, not on your way up. So it changes the dynamic on how you're practicing. Another thing that you will also have a better understanding is that every time that you start getting close and away from the area of interest, this is called the defocusing component, which means that the closer you are to the area, the more energy is going to be deposited. The further away you are from that area, the less energy is going to be deposited. So because you don't have that tactile sensation, we're going to have to start, using a lot of visual cues here to be able to see where is the tip of the laser in relationship to the tissue that we're working on. And if the laser is not doing what you want it to do, you have two options. You can increase power, or you can get a little bit closer to the tissue and let the laser do its thing. So in order to better explain this, one of the interesting things about lasers is that we sometimes tend to think that a larger tip will have a more power density than a smaller tip, and it's not quite true. So I want you to see here, the moment that we have a larger tip, the energy is not the same. A smaller tip, the energy now gets more concentrated. So it's the same thing here with the lasers, okay? When you have smaller tips on lasers, they will have a significant difference in power density. So the smaller those tips, the more penetration you will have here, and this is when you can get to danger. So one of the things that we tend to use, at least myself, I like to stay in between those two sizes of tips. I typically love to use a 400 micron tips, which is in between. It gives me everything that I need. And then when I'm dealing with more of a calcified canal, something a little bit thinner, then I'll start going very thin. I start going towards the 300, maybe a 200, but I have to be very careful because the smaller the tip that you have, there is a likelihood that you can actually ledge the canal if you're not paying attention, if you're binding to the walls of that canal. So just be very careful of that, particularly if you are using a very small tip. But in the end of the day, everything, it's about the bubbles, right? So Dr. Barnett always likes to quote, this is all about the bubbles, all about the bubbles. So in endodontics, how are we going to make those bubbles work for us? Let's start by understanding, how do I use lasers? So laser, it's definitely not a one trick pony. There are many, many applications for lasers in dentistry. So this is the Merida laser, and those are all the applications that this guy, it's approved for. Now, when we talk about root canal disinfection, that's what most endodontists are thinking, but there's a lot of things that you can use the laser for, okay? But when we start talking about the bubbles, you have to imagine that the laser is going to come and is going to increase the temperature around that liquid. And as that laser, okay, increases the temperature, it evaporates the liquid around the tip. That evaporation is going to cause this rapid expansion of the bubble's radius. And during this expansion, the bubble is going to increase this internal pressure, and then it's going to start moving with a lot of force as it collapses. So this particular energy here creates a shock wave which is emitted at the time of the bubble collapse. And then more bubbles are actually created within this cycle. So when we say that it's all about the bubbles, what you're seeing here is just in one bubble creation. It's actually happening multiple times within a second as the laser activates the irrigants inside the root canal system. So this sheer energy of the bubble expanding, collapsing, moving in high velocity, and heating the dentinal walls. And then as they heat the dentinal walls, they explode and they interact with the biofilm. They can remove the biofilm from the dentinal walls. They disrupt the chemical components of the biofilm. It is really interesting. And that's what causes the cavitations, right, of the laser within the root canal system. So when you are here, this is what we just observed. This is one bubble that's being created, collapsing, moving in high energy. That's going to go through the root canal system and it's going to hit those walls. Now, what I want you to see here, it's the lasers in action, and you can see the amount of bubbles and the billions of bubbles are being created now, and the sheer force that those bubbles are actually creating to interact with the dentinal tubules and to remove, right, together with the irrigation solution of choice, whatever it's inside that canal that the laser can affect. So when we look here, we're looking now at a root canal system, and we're going to see the activation. You can see a little bit of the dye here. Here comes the laser. And the laser part, guys, it's invisible, okay? One thing that I have to tell you is that the laser is invisible. You cannot see the laser in action. What you're seeing here is just the aiming laser. It's one thing that sometimes people don't know. The aiming laser, you can turn it on and turn it off. It really looks like one of those lasers that you use for your PowerPoint presentations. It's really just to help you aim at the area of the root canal system that you want, particularly canals, particularly when you go inside the canals. So when you're here and you start now activating the laser, you can see the bubbles coming in all the way to the bottom of the bottom. So we are far away from the apex, but you can see how the lasers and the bubbles keeps going in, and it starts to work towards the root apex. You can see when the bubbles are going. Every time they're going, as we create this shear force, right? As they actually expand and collapse, they also create this negative pressure inside the tube, which prevents the intrusion of the root canal system. One more time, just pay attention, close attention here to where and this little popcorn sound, here, the popcorn sound, hertz, or how many pops, or how many times this laser is actually pulsating inside the canal system. So in reality, what you just saw, and this is a video from the water lays, just showing, that when that bubble comes in and it's created, it really collapses, moves in high velocity, explodes, creates the shock wave. This shock wave creates more bubbles, and that's what's disrupting the biofilm and going inside the dentinal tubes. So whenever you start using laser, when do you start using the lasers? Well, you can start lasers all the way from your restorative component, you can do your access, but traditionally speaking, after you finish your access, this is the first time you're going to use a laser in endodontics, we're going to do something called laser cystic corona conditioning. And what is that? This is now the idea of getting in the laser and remove the bulk of the access, all that slime, all that junk that's inside the coronal part of the tooth, you can now clean that with advanced irrigation. So the protocol that we suggest at Einstein is that you do your access. You always do a lot of block out around the tooth. So one of the things that I tend to do is make sure that there's enough seal there. We don't want patients tasting anything as it goes along. Sometimes depending on the power, depending on the access, depending on the tooth, even depending on how your assistant is supporting the irrigants inside the root canal system, you can create a little splash. So one thing that I always tell folks that are using lasers, particularly in the beginning when you're not quite there yet, you're still learning the process, is just be careful with splash. So make sure to cover your patient's clothes so there's really no accidents there. One of the best things that I learned in Einstein was to actually use saloon aprons, right? So just the same ways that you get at a barbershop, you're very cheap on Amazon. You can cover your patients with that. The patient feel very comfortable around that, and you protect their clothes from any splash, particularly in the beginning when you're learning how to use this. As your assistants get better and they get to understand the flow of continuous irrigation, then this becomes no problem. So basically what we do is we activate the laser for 30 seconds, and we get amazing results when it comes to the cleanness of the coronal part of the tooth. This is going to enhance the color map visualization of the tooth. Definitely starts to remove poke stones and anything that can be blocking you from visualizing the canals. As I showed you before, as you're doing this, it's also sending energy and sending irrigants inside the root canal system. So it starts the disruptive of biofilm immediately. And as you start to progress with your keys, it definitely helps you achieve apical patency. I have no doubt of that. Every time that I got myself in trouble, that I was trying to blocking myself, all I had to do was to run the laser for about 30 seconds. And sure enough, here I go again, and I can achieve my patency. Okay. It's definitely safer to irrigate the canal, also during the coronal conditioning component, because you're not really, particularly on younger patients. So if anybody here see kids, at Einstein, we saw a healthy population of 8-year-olds, 10-year-old kids there with really large apex, and using a laser was never an issue on those patients. Another tip that I'm going to give it to you, it has to do with the fact that because there's no tactile sensation, particularly on the Merida laser, it's important to remember that those tips are reusable. So you have to be very careful when using the laser, particularly close to areas that have hard tissue, because here's an ablation. So you can see here, as one pulse came out to the hard tissue, you can see how much debris came out of that hard surface there. So if you are too close on hard tissue with the laser, it's possible that this debris can come back and hurt the tip, and therefore, your tip is not going to last as long. So one thing that I always recognize is that if you always activate your laser with water inside the tooth or with some sort of irrigant inside the tooth, and if you are going to do something dry, be very mindful of your angles, so you're not on a direct angle to the surface, and therefore that debris does not destroy your laser tip. So one of my good friends from Canada, Dr. Benyamu, who is a phenomenal periodontist, one of the best in the business when it comes to laser and perio, always talked about the fact that, for example, if you're doing perio around the tooth, you always want to keep your tip at a 45-degree angle to avoid this particular error here, and therefore, destroy your tip. So when you start your laser, your irrigation, this is what you're doing. You're coming in and you're doing your coronal conditioning. This is me just doing a coronal conditioning on a tooth. It's continuous irrigation. And as you can see here, the laser is just at the coronal surface of the tooth. And look at all this junk that's coming out from the root canal system. So you can clearly appreciate what the laser is doing. Now you know what it's everything about the bubbles, right? So all those bubbles are coming in and they're going in there, and they are now disrupting all this, all this junk that was there before You can see how everything is going there. You can kind of go in and do your suction. Much better visualization of the root canal system now. It's going to be fantastic for you. And so you can go for something like here to the left, here to the right. This is a case from one of my co-residents, Dr. Ben Schwab, right in the beginning when we were learning how to use this. The coronal condition component, it's truly something amazing that, you'll start to get the coronal part sparkling clean, ready now for your instrumentation. So here's another good example of how coronal conditioning can help you with the beginning of the root canal system. Obturation. Instrumentation, I should say. So here's a necrotic case, very much junk on the left. You run your coronal conditioning. The canals are much more visible. The column map are amazing. And then you can start going in now for your traditional instrumentation. So here are showing just a few cases removing a little bit of pulp stones. So again, phenomenal ability to remove debris from the coronal part before you start your instrumentation. So here's one of my cases, before and after. Just finished my access, going in 30 seconds of sodium hypochlorite, and I have this beautiful openings in front of me. The canals are literally just staring at me right now, so I can go in and start my instrumentation. So what makes the Merida laser different than the other lasers that are available on the market today? The reason why I chose the Merida laser for my practice has to do with many things. The first thing was I wanted a laser that was just not for irrigation, that I could use for hard tissue and soft tissue. The second part that to me was really, really important was that I wanted a unit that was self-sufficient, meaning that I could move this unit around very easily, and I don't need to plug this unit to a air line. So the Merida laser will come with its own compressor, which makes your life much, much easier because it's one less problem, one less connector that you have to deal with. One of the interesting things about the Merida laser, and I've talked about this with some other colleagues around the country that are using the laser now, it's how light the handpiece feels in your hands. I think the way this arch comes, the way this arch is with the Merida laser is just fantastic. It makes the handpiece very, very light. And another interesting thing about this laser is that it requires almost no maintenance. And this is something that makes Merida fundamentally different than any other laser company out there. So what do I mean by this? So all other laser companies, they will require something called laser maintenance. What is this laser maintenance? So there are two components to it. Number one, it's your mirror maintenance. So inside the other handpieces on the other lasers, there is a mirror. And unfortunately, all the other laser systems that I have used, the seal between the tip and that mirror, it's not perfect, which means that those mirrors, they have to keep consistently being clean. I have colleagues of mine that clean those mirrors between treatments. And over time, they do decay, and this is an expense that you have to, you will have moving forward with your lasers. The way the Merida tip works, particularly this part right here, there is no mirror. The tip is coming, the laser is actually coming, the laser tip is coming right here, and there's really no mirrors for you to deal or clean. So during my time with the Merida laser, I never had to do any maintenance. Interesting enough, I had talked to colleagues of mine who are periodontists, and I asked them, so how long have you had this laser? And they were like, well, I had it for 10 years. And I went, so how many mirrors, how many times you buy mirrors a year? Or, tell me about your maintenance. And they look at me like I'm crazy. They don't even know what I'm talking about, because they have never had to change mirrors or deal with any issues related to maintenance associated of the splashing from the irrigants inside the handpiece. So this is a huge advantage of the Merita. The other thing too that's interesting is that the Merita doesn't need priming. So it's a unit that you turn it on, and in 20 seconds you're using the unit. All the other units on the market today requires you to prime the unit, and that can be pretty fast, maybe 2 minutes or so, but sometimes it can be a problem if something is going wrong. So the fact that there is no priming of the Merita in the morning, I can just turn it on and start working. And in the end of the day, I don't have to do anything at all. I can just turn off the unit, and within 2 seconds, I can leave the room and leave the office. Is also awesome. So from a workflow perspective, sure, interested in laser, I would encourage you to check this out because it's something that really, really makes a difference to me. And another thing too that is also important is how those tips were developed. As you can see here, those tips are curved. They really look like the tips from an ultrasonic unit, which everybody here is very used to it, particularly with finesse. So the fact that this looks like an ultrasonic tip, it gives you extremely great visibility when you are going inside the root canal system. So here is one of my cases. As you can see, this is what I would definitely see inside the root canal, and you can see the tipping there, and it's not blocking my view. So other lasers, whenever you have to go at a 90-degree angle, because of the big head, right, just like a handpiece would look like, you won't be able to see this as clear as you can with the Merita laser. So it's a fantastic design that I like it very much. One of the things that is also going to be questionable is going to be, should I take the tip inside the canal? Should I keep the tip on the cervical part of the canal? We can have this discussion in another time, but with the Merita laser, you can pretty much do both if you choose to do so. If you don't feel comfortable taking the laser inside the canal, you can use a larger tip like the 400 tip and work with the irrigants only at the coronal surface, and you will work great. Or you can take the laser inside the canal and truly take advantage of that power density part that we were talking about before, and have the laser really do its things and help with irrigation. So this is a root canal that was sent to me by Dr. Barnett. Was Dr. G. Lean from Iceland. She's a first-year resident there, and this was her first case using the Merita laser. So she was able to instrument this tooth and get amazing results with the Merita laser. Great anatomy, great case, first case from a first-year endo resident with this particular laser that is literally just starting to get trained on it, and the results are already amazing. One of the things that she did was she does use irrigation, taking the tip about mid-root, and when you take the tip mid-root, you clearly can deliver a lot of energy, a lot of irrigants. You put those irrigations on steroids, and therefore we can get great results. Here's another case from another Merita user from Arizona, Dr. Moavin, and here he was looking at this molar right in the beginning. Again, he's a more experienced endodontist, but he had just got the laser, and this is one of his first cases on the second molar there. So again, amazing results that you get with the Merita laser. It's exactly what I get when I am using this particular system. So from a clinical protocol perspective, since we are just about to wrap it up here, it's important that you start with your coronal conditioning, and every time that you go in with your file, you can do about 30 seconds of hypochloride plus 30 seconds of resting time. So the idea is whatever you use for your main irrigation, whether it be hypo or Triton, you irrigate for 30 seconds, let it rest for 30 seconds, and then go to your next file. And after you got to where you want to be, again, 30 more seconds of irrigation per canal, 30 seconds of resting time. Then when you get your working length and you start using your files, is the same thing. You're going to use your files to get to your working length. Use your laser for about 30 seconds with continuous irrigation. And in the end, here's your final protocol. I would start, and every time I use a file, I'll go 30 seconds of hypo, after I finish with my last file, I will do 30 seconds of water. Those 30 seconds of water will remove the hypo. I'm going to do now 30 seconds of EDTA, followed by 30 seconds of water, followed by another irrigation of hypo, and I'm going, as you can see here, we typically stay about mid-root. We don't go all the way down. We like to stay about mid-root. I want to make sure that I'm not binding to any walls as I'm doing this. And in the end, I do another 30 seconds of water, dry the canal, obturation, and we call it a day. So with that said, I think my time here, it's about done. And I just wanted to show you some research, some amazing research that is being done now by Dr. Fernando Meza. And what he's showing is the advantage of taking the laser tip inside the root canal system. And what you see here, it's the penetration. And this is what you see on this, particularly here on the left. This is needle irrigation. This is what we are doing today. And he did this with a dye. And what you see on those other two slices here, it's actually the penetration of the laser, of the dye inside the dentinal tubules with the laser tip inside the root canal system. So this has, an amazing result. Being able to see how deep those lasers are penetrating inside the dentinal tubes, it's exactly what we were talking about. We have to kill microbes. We have to make sure that we disrupt biofilm. So with that said, I think it's awesome that you guys were able to log in here with me tonight. And I will definitely see you next time. So thank you very much for your attention. And I'll see you around. So I'm just going to pull up here to the side. We got a couple more minutes left. So I got a question here from Dr. Mirai. Gentle wave irrigation system can penetrate biofilm in hard to reach areas. I don't dispute that. Both technologies are great. I think they're both complementary of each other. I'm not in one camp versus the other. If you were to ask me, both are great. You can use both. But as is demonstrated today, there is a difference between, a closed system like gentle wave that only does one thing really well versus something that does that same thing really well as well, but has other protocols that you can use, such as hard tissue surgeries, and allows you to even extend the amount of time that you want towards irrigation if you decide to do so. So the next question here is from Dr. Song. He's saying, Dr. Song is saying, can you compare the effectiveness of root canal disinfection between laser and ultrasonic endoactivator? So absolutely, the research has shown that lasers has a much more profound effect on this. And if anybody's interested in getting those papers, just please send it to me, your email at bruno@combinguy.com, and I'll be happy to send you the literature that is quoting here. So next question is from Dr. Mary Chen. She's saying, what is your settings for coronal conditioning? So for coronal conditioning, I like to start with the 400 micron tip with the Merida, and I will use 30 millijoules and 20 pulses per second. Also, Dr. Shen is asking me, what are the types of irrigants that I use for coronal conditioning? You can use sodium hypochlorite, but let me tell you, Dr. Shen, when I was at Einstein, I did research with Dr. Carlos Estrela in Brazil, where we were using laser irrigation protocols, and we were comparing hypo and Triton. And the results from Triton were better than hypo. So Triton is an irrigant from Brasler. It's a combination of sodium hypochlorite and EDTA. And I use that. I really like that irrigant. So I know that there are other endodontists out there, they're in the laser world, that are switching to Triton. And I would encourage you to take a look and see if this is good for you. But this is what I use. But there is no problem with using hypo. One of the things that I never mentioned was the hypo concentration. You can be at 5%, but in the beginning at Einstein, because we were, again, dealing with unexperienced doctors, we were using 2.5% hypo, and then we increase the the percentage of hypo moving forward, as we knew there was really not a lot of issues with extrusion. So next question here is from Dr. Sean. Dr. Sean, can laser be used for GP removal, good aperture removal? Do you still require GP solvent for treatment cases? So yeah, so you're not going to remove the good aperture cones with lasers, okay? That's going to be a mechanical instrumentation, but there are remnants of the good aperture that the lasers can be definitely used to remove. So the bulk of the good aperture system is going to be removed by mechanical ways, such as a file or rotaries. And then after you do that, you use your laser to clean up the canal and remove the bulk of whatever's inside there. So it's actually a phenomenal way to do it. So, and then the question here is from Dr. Park. Thank you for your presentation. I remember there was a slide about laser applications in a wide range of dentistry. Do you know the Edge Pro laser can be used for around periimplantitis? The answer to that is very simple. It's no. The laser from Edge Pro, again, great laser, YS2G. The only thing about that laser, it's only for irrigation purposes. It is extremely slow if you try to use that on soft tissue. I would not recommend that. But there's no applications in periimplantitis or surgery or body cutting bone. It doesn't have that power. It only is solely for irrigation. That's what that laser is for. Okay? And I think with that said, we are good. Any other questions? Anything I need to do? Great, guys. I appreciate you.